Welcome from the Centurion Lounge in Atlanta. So my regular scheduled AMA in an hour is actually going to be a little bit pushed up because my flight's delayed about 2 hours to get back from Atlanta to St. Louis. So I've been attending the American College of Cardiology conference in Atlanta over the past 3 days and learning about the latest and greatest in the cardiology world. So it's been many years since I've been to this conference. I've usually attended a lot more functional integrated medicine conferences in the past few years, but wanted to see what was new in the general cardiology world and wasn't disappointed. You know, the AI explosion in the cardiovascular fields is very impressive. I mean, there's a lot of gear that I already have in the office that can already utilize some AI. I've been doing the Cleerly scan for the past, almost 3 years now, and they're a big presenter in the expo hall. They have a big trial that they're enrolling for to look at patients who are at higher risk of coronary disease versus general standard care to evaluate people's cardiovascular risk. I have the Echo 500 probe. I talked to the vendors today. They're rolling out software where you can actually detect if there's low ejection fraction or not with this EKG. And then there's a couple different epigenetic companies that I talked to. Diagnostics was one of them. And they have 2 panels that I'll be bringing to Apollo Cardiology in the near future. They can tell you your 3-year risk of having a cardiovascular event or if you even have coronary disease. So really cool technology in the expo hall. I'll probably have a bigger write-up at a later time. But the big take-homes, like you don't want to end up on the cath lab table for most of these guys. There's still a lot of drug therapies that are being promoted here for people who are really, really sick. So always interesting that the technology is available for them, but obviously I'm trying to prevent you from ever going down that route. Not a lot of preventive cardiologists walking around this, but I did meet a couple. Actually did get recognized by one integrative cardiologist who came up to me when I was standing at a booth talking to some of the people who do some of the 24-hour blood pressure monitors. Other big take-homes, there are some great technologies coming out for Lp(a). Hopefully in the next year or two, there's small interference RNA technologies, they're antisense oligonucleotide technologies. Right now, there's a big push on getting people tested. They actually had a very long line for people to get their Lp(a) checked if they wanted to. I've been checking Lp(a) levels for almost 10 years now, and mine is normal. And they said that apparently less than 2% of the U.S. population knows that they have elevated Lp(a) or not. And if you have elevated Lp(a), it definitely significantly increases your risk of cardiovascular disease. It's more atherogenic and more thrombogenic. So at least it's good that the general cardiologists are finally talking about this. So there were some good questions that were submitted ahead of time. I'll answer those, and if there's some more that pop up, I'll answer those as well. First question up tonight from the Amex Centurion Lounge in Atlanta. CoQ10, ubiquinol, is it worth taking? Also nattokinase for atherosclerosis. So ubiquinol is not needed for all. Mainly if people have low levels because they're on beta blockers or statins, it may be reasonable to supplement people with it. Or if they have atrial fibrillation, high blood pressure, congestive heart failure, maybe it's worth supplementing. And generally you're supplementing to get a blood level over 3, using either ubiquinone or ubiquinol. And second case, nattokinase, more useful if you have elevated fibrinogen levels, not necessary for all. There's a similar question. Somebody says, do I recommend supplementing with CoQ10 and what dosage? It's whatever dosage it's required to get your blood levels over 3. Sometimes that's 100 milligrams, sometimes that's up to 300 milligrams, sometimes it's up to 600 milligrams. So whatever dose gets you over 3, and has really no effect on lipoprotein. So if your ApoB is 97, you'd really need to know what your coronary arteries look like or your carotid arteries to say, is that level high or low? But if you are on statin therapy to try to lower ApoB, you may consider supplementing with CoQ10. Yeah, and a quick side note on that there was a trial here that had looked at HDL. They infused ApoA1 in patients after a myocardial infarction or heart attack. And it showed that there was no benefit. So trying to raise HDL, giving people infusions of what was basically an HDL mimetic, had no benefit. So the basic take-home from that test was trying to raise HDL artificially doesn't work, and probably would be better just focus on lowering LDL particles, ApoB particles. So HDL, I heard somebody joke, was like, maybe it's not good cholesterol anymore, it's just, it's okay. So don't focus so much on your HDL cholesterols right now. question about spike proteins. So spike proteins, yes, they can damage the endothelial glycocalyx. That can affect nitric oxide levels and can then lead to thrombosis in the microvascular system. So definitely possible to damage the endothelium with spike proteins. Question is, hydrolyzed collagen cardioprotective? I've not seen any studies that it would be. Collagen is the most abundant protein in your body. But yeah, I tend to think of collagen as more of a protective for your skin, hair, nails, and that you need complete amino acid profiles for your skeletal muscle and your myocardium. So yeah, it probably is useful to have collagen, but it's not at the expense of having kind of a full spectrum of protein, especially the amino acid leucine. Next question up tonight. Do I have an opinion on low-dose Cialis as a pre-workout aid, and how does it affect blood vessels and epithelial function? So low-dose Cialis, or tadalafil, probably does help somewhat with pre-workout, because it is going to dilate the microcirculation. So it would help with promoting nitric oxide retention. So think of nitric oxide as needing to be produced during exercise, or when you're out in the sun, getting UVA light on your skin, or you're eating a nitrate-rich diet, greens and beets. If you have tadalafil around, you're going to keep that nitric oxide around longer, dilating the arteries. So it may be beneficial. Is there any studies that show that? Nope. Is it FDA approved for that? Nope. So you're kind of on your own for that. Next question up is, Calroy's Vasconex similar to taking aged garlic for nitric oxide and cardiac support? So in full disclosure, I've done some webinars and educational content for Calroy in the past as a paid speaker, so this doesn't affect my response here. But Vasconex, it does help promote nitric oxide for over 24 hours. It also has a vasodilator that is due to the hydrogen sulfide that is contained in the product. Hydrogen sulfide acts a little bit like a phosphodiesterase inhibitor and keeps the nitric oxide around longer. There are some garlic type ingredients in Vasconex. It is not exactly the same as Kyloic aged garlic. So I have many patients that are on both Kyloic aged garlic and Vasconex. But think of the Kyloic aged garlic as more as an anti-inflammatory. It's somewhat of an effect on the plaque stabilization, and also because it has a lot of sulfur in it, it's donating that to the glycocalyx and potentially helping improve the structured water, the easy zone water in the glycocalyx. All right, so somebody's asking about new things from the American College of Cardiology conference I'm just finishing up. Anything with effective plaque removal from small arteries. That is definitely not discussed in any of the big conferences, things that I attended, and I was trying to look very hard in the app to find anything that was related to the glycocalyx or nitric oxide. And there's maybe a couple of posters on nitric oxide, but nothing on the endothelial glycocalyx. There was some talk about microvascular disease, but it's mostly in the context of using PET-CT, very expensive technology to find it, or cardiac MRI, also generally very expensive, not covered by insurance for most reasons. So no, there are not any discussions on medication treatments for plaque removal at this type of conference. And you're very welcome. That you guys are very appreciative of this. You're very welcome. All right, and next question up. Somebody's asking me, what is my preferred statin medication and why? I mean, this is just my clinical experience. I typically prefer either Pravastatin or Rosuvastatin. A couple reasons. One, there are generic varieties of them. They are not fat soluble, so may have a little bit less side effects from blood-brain barrier reasons, maybe less muscle symptoms. Pravastatin has not been shown to raise glucose compared to some of the other statins, particularly the atorvastatin and simvastatin. So typically we'll use either of those. I tend to use rosuvastatin if people have known vascular disease. If it's more primary prevention, maybe I would use more pravastatin. All right. So I think I got the pre-submit questions. Thank you for those who are joining now. This is live from my phone booth at the Centurion Lounge in Atlanta. My flight was delayed a little over 2 hours, so I'll be on the plane with my normal IG Live would have gone off. So I just wanted to answer the questions for you guys tonight and give you a little bit of a quick review of what I learned in the past 3 days at the American College of Cardiology conference. So lots of cool stuff on the horizon, a lot of AI-enabled devices and lab that look at epigenetics. So some of this stuff is going to be rolling out Apollo Cardiology in the very near future. That's what I really enjoy about being in private practice for myself, is that I can change things very rapidly. I don't have to ask any hospital administrators or anybody, mother may I. So if it looks cool, looks like it's validated, it's going to be up and going in the next couple days at Apollo. So my team better be ready when I get back. So somebody's asking, what would I do for very high ApoB? I did attend some lectures that talked about homozygous familial hyperlipidemia, which is very rare. Less than 2,000 people in the United States have it. That would be the case where you're probably going to be on triple therapy, high-dose statin, ezetimibe, and then a PCSK9 inhibitor would be kind of the starting cocktail for most of those patients. There are a couple other drugs that are out there. If you're homozygous familial hyperlipidemia, you generally have to be at a specialized center because some of these drugs have a little bit more liver toxicity. Mipomersen, that's an MTP inhibitor. I've never prescribed it to anybody because I don't have that kind of patient population. Then apheresis is also an option. I did see a booth at the expo hall talking about their apheresis device. So apheresis is a procedure where your blood is taken out, filtered through a machine, and your blood's given back to you, and they pull out the ApoB particles. This is also useful for patients with high Lp(a). That's really the only approved treatment for it at this time. The other question is, if you're statin intolerant, then bempedoic acid, or which is also known as Nexletol, could also be useful. It's an ATPase citrate lysase inhibitor. So it acts a little bit similar to a statin, but doesn't get into the muscles and cause any of the symptoms. So somebody's asking about a blood pressure question. Yes, I did not get a chance to attend any of the live talks on hypertension, but I did post in my story about that there's a twice-a-year injection that will help lower blood pressure for people who can't get to goal. That's a very interesting proposition because sometimes people get pill fatigue or they start getting side effects from taking multiple medications. So this might be an option for some people. But low blood pressure is a different option. If you're symptomatic, dizzy, lightheaded, feel like you're passing out, weakness, shortness of breath, chest pain, then low blood pressure could be a problem. My resting blood pressure, I have one of the non-validated blood pressure monitors on right now. I can do a photoplasmography and a cuff-based blood pressure at the wrist. My resting blood pressure is usually somewhere between 95 and 105 systolic, and I'm not dizzy or lightheaded. But if you are symptomatic, then hydration is very key. So at least ½ ounce of water per pound of your body weight. Salt tablets, would probably be useful for that case. And then depending on what other medications, you might want to talk to your doctor about a medication called midodrine, which would actually raise blood pressure. So don't use it often. I've used it in a few people, but it's mostly people who have a lot of issues with syncope or passing out. So question, if there's a calcium score that's less than 50 to 100, what's the target LDL level? So this is where it's going to get a little bit nuanced, because there's a lot of data on, secondary prevention. You've had a heart attack, you have stents, bypass, stroke. The LDL-C target is not less than 55 milligrams per deciliter. Now, when people are true primary prevention, never had an event, well, have they looked for enough? Most of the time, these studies aren't necessarily including a calcium score to say the person is truly primary prevention. You're kind of a, 1.5 prevention if you have a positive calcium score. Now, If a calcium score is over 300, that's considered a coronary artery disease equivalent. So if you're definitely over 300, probably your LDL-C target is 55. But I'm a little bit more aggressive, is that if we have any amount of calcium in your arteries, you show that you have evidence that you can have glycocalyx destruction, endothelial dysfunction, vascular inflammation, plaque buildup. So lower is likely better for you. So I probably would shoot for that same LDL-C goal of 55 or less. But I don't tend to use LDL-C as the target. I'm looking at the LDL particles because particles predict risk better. And you can just look at ApoB because it's going to include all the LDL particles, the VLDL particles, and LPLA particles if you have them. So I usually shoot for ApoB targets. Most people's ApoB should generally be less than 70. If you're higher risk, less than 55 on the ApoB. Somebody's saying, what is the concern about a young person's low HDL? There are just certain people that have genetically low HDL. You can do a GB Insight panel to figure out which gene that may be affecting it. But if it's not genetic, got to make sure the person's not insulin resistant. That's often a common denominator for low HDL. Poor sleep may drive it. 19-year-olds are probably not drinking a lot of alcohol, but if you're drinking too much alcohol, definitely with lower HDL. And then the other big one is steroid abuse. You see that not uncommonly in younger people if they're using anabolic steroids inappropriately. But that being said, just low HDL by itself does not necessarily mean you have a problem. You need to look at the ApoB side of the equation, because if that's high, then you're more prone to having vascular disease. So somebody's asking about a target LDL level. I kind of went over that one. All right, so somebody's just saying hello. I haven't spoken to you since Silverback, so how's it going, Matt? Good to hear from you. So somebody's asking about how far should they be from their red light, near infrared light, like a Juve. You're going to have to actually look at the manufacturer's recommendations because every device has a different radiance and different EMF emission. So don't know unless you look at the actual manufacturer's specifications. But this is where it gets a little bit tricky, is that most of the panels, they're going to blanketly tell you just 6 inches away. Well, that's not, based on any type of science. It's just more of a CYA for them. The better treatments are that it's closer. Red light, the acronym is RATS, reflection, absorption, transmission, scattered. When the red light's bouncing off your skin, 63 or something like that % of the light bounces off your skin. So the closer it is, the more the photons of light get absorbed into the tissues and actually have a benefit. So probably in the future, more and more of the devices are actually going to be topical. You're actually having like a wrap, then you're going to put the photons directly up toward this layer of the skin and get them to absorb better. It's probably the way it's going. So would I recommend testosterone replacement therapy for someone with testosterone at 390, FH diagnosis on ezetimibe and statin? All biomarkers are good on 2 blood work panels with a cardiologist. So very good question. I did attend 2 different talks today on testosterone replacement therapy. There's a meta-analysis of there's at least 9 different trials that show that there's no increased cardiovascular risk with testosterone replacement therapy when levels were kept in appropriate ranges. What's appropriate? Generally, it's going to be less than 750, and that's more per the Traverse trial that recently came out. The Traverse trial was only using the testosterone gel, not been studied with injections, not been studied with pellets, and it was in people who had 2 testosterone levels less than 300, 48 hours apart. So you had to have a level less than 300, you had to be symptomatic, low libido, ED issues, brain fog, insulin resistance. You had to have some type of symptoms. They didn't treat people who were asymptomatic in those trials. And the concern would be, do you have any other risk factors? No history of pulmonary embolism, thromboembolism, atrial fibrillation, or kidney failure, because those were slightly increased risk in the Traverse trial. So just having an FH diagnosis on lipid-lowering therapies is not a contraindication to be on testosterone replacement therapy, but a level 390 doesn't mean that you necessarily need to be on it if you're not symptomatic. Somebody's asking, are there any studies for those that saw an astronomical increase in PVCs after getting exposed to COVID? That's not an area that I'm keeping up to date on all the trials, but it was definitely reported that, within 9 months after a COVID exposure, that people had more PVCs, premature atrial contractions, and atrial fibrillation. The mechanism of action is likely that the spike proteins are damaging the glycocalyx to the microcirculation to the myocardium and the pacemakers, the sinus node. So that is probably the reason why. So things that can promote nitric oxide production. There's different supplements can do that. Lowering oxidative stress and inflammation are key. And then there are other things like photobiomodulation that may help. This is a little bit more nuanced, but I'm not going to be able to go deep into it. But somebody's asking, is meat okay or not? The short answer is it's okay. Is it cancerous? Not generally, no. And as a matter of the individual sensitivity, it matters what your animal ate. That's always the key. People overcomplicate food. Food is a photosynthetic barcode that this is what Dr. Jack Kruse talks about. Photosynthesis grows the plants. You go eat the plants. Your mitochondria break it back down into sunlight, essentially. Electrons that go through the ATP, go through the mitochondria. Or you eat the animal that ate the plants, and then your mitochondria's job is to reverse that. So you're mostly eating to capture electrons. Think of it like Pac-Man. You get electrons from food, you get electrons from sunlight, you get electrons from grounding. So you don't have to get all your electrons from food. So meat is generally okay. You really need to focus on high quality protein. You don't have to get protein from meat, but it's just a more convenient source. It is actually going to be more nutrient dense. You can do it plant-based, you just have to plan it out, and you have to be accounting for the carbohydrates that come with the plants. Somebody's asking, what do I think about diet soda? I don't think it's fit for human consumption, is the easiest way to think about it. But this is also coming from a former soda addict. I literally had a soda machine in my place for a while, and I was drinking multiple sodas a day, over 2 liters of diet soda a day. There's probably no safe amount that I would think that people should be consuming. It's going to mess with your gut microbiome. It's going to affect, the way that your pancreas secretes insulin. So, water, coffee, tea, those are probably the best liquid things to drink. Somebody's asking about reducing saturated fat or reduce the amount. It depends. Depends if you're sensitive to saturated fats, raising your lipoproteins. If you're an ApoE4 carrier, possibly. If you're a hyperabsorber of sterols on the Boston Heart Lab panel, possibly. So you want to have a baseline and then see where your labs go if you've changed the amount of saturated fats. There's a fatty acid balance test on the Boston Heart panel that will tell you how much saturated fat you're currently getting in your diet. All right. I'm not seeing any other questions pop up at the moment. I think I got about 15 minutes to make my flight. So I appreciate you guys jumping on here earlier with me. So I'll be back from St. Louis. I should say I'll be back from Atlanta in St. Louis later tonight. And then I'll start dripping out some of the things I've learned over the past few days at the American College of Cardiology event down here in Atlanta. So hope you guys have a great week, and we'll see you next time.